Hi class, I am putting this online for you guys to listen prior to us meeting on Wednesday, as this is a very confusing subject for many, but the more you're able to review it, the better you will understand it. So what I need you to do is listen to this, do your readings. Iggy chapter 12 does introduce this acid-base balance, and it is not a very long chapter, and it is relatively easy to read. And also Fluid and Electrolyte Review is your chapter 11. And then when you come in on Wednesday, what I would like to do is give you a bunch of numbers that we're going to be going over here and let you guys try to figure out what exactly each one means. And again, the more you practice it, I think the better you will be and the more successful you will be when it comes to testing. So today's lecture, I'm going to go over the mechanisms that maintain acid-base balance, differentiate between respiratory and metabolic acidosis and alkalosis, and identify laboratory and diagnostic tests used to determine your acid-base balances. So how is an acid base regulated? When your pH rises or falls, there's three regulatory systems that come into play. That includes your buffer systems, which I'll go over, respiratory system, and renal systems. Your regulatory mechanisms comprise first of your chemical buffer system. What the chemical buffer system does is it will absorb excessive hydrogen ions, which is your acids. This is your first line of defense, and this will act immediately to protect tissues and cells and to neutralize acid or base until other regulators can take over. So again, this is your first line of defense, and it does act immediately upon response. Your bicarbonate carbonic acid buffer system is also included in this, your phosphate buffer system, and then your protein buffer system. Your protein buffer system is the most common one, and this is a very rapid response also. This includes your albumin, your globulins, and your hemoglobin, which binds with your hydrogen dioxide. Your respiratory system is your second line of defense against your acid-base imbalances when the chemical buffers alone cannot correct your blood pH. This will occur within minutes, so this is also pretty fast, but not quite as fast as your chemical buffer system. If a patient is hyperventilating, they will retain acids. If they hyperventilate, they excrete acids. Your lungs relate to carbon dioxide that combines with water to form carbonic acid. So what does this mean? Your chemoreceptors in the medulla of the brain will sense your pH changes and vary the rate and depth of breathing to compensate. So if you have a low pH and a high CO2, you're going to increase your respiratory rate to blow off excess CO2. If you have a high pH and a low CO2, your respiratory rate will be decreasing to retain CO2. To assess your ventilation, you want to look at your PaCO2. And up here is the normals, which is 35 to 45 milligrams of mercury. And if this seems a little bit confusing, please don't worry. We're going to go into more depth throughout this lecture. The renal system is your third line of defense. This will occur within hours or days, so this is not a quick response, but it is a stronger change. But again, it is slower. Your kidneys will excrete or conserve acids and bases into the urine as needed. It can produce bicarbonate, and this bicarbonate level will be reported with an arterial blood gas, or an ABG, as you guys will hear it, and a normal of this is 21 to 28 milliequivalents per liter. So I'm going to have these all listed later in this lecture, but these are some numbers that you will need to memorize. Your acid-base imbalances occur that will cause hormone imbalances, electrolyte imbalances. They will make your cells excitable, and it will decrease drug effectiveness. So it is important that we do maintain homeostatic responses in our body to have the best outcomes. Acid-base imbalances are classified as respiratory or metabolic, which is your primary cause. And then it's also classified as acidosis or alkalosis, which will show the pH of your blood. Primary or simple imbalances are usually due to one cause. One cause can be respiratory failure, which will cause respiratory acidosis, renal failure that can cause metabolic acidosis, and to keep your pH in normal range, there may be a compensatory response, and this you're actually going to go more in depth in Nursing 281. We're just going to kind of go through most of the basics today, and then you can build on that from here. There is also mixed imbalances that occur when both metabolic and respiratory imbalances are present. Some examples, or an example of this is a cardiac arrest. When someone goes into cardiac arrest, they will also cause respiratory and metabolic acidosis. So again, this is even worse than just having one or the other. You have more things to correct. This here is just a picture of trying to help you remember alkalosis is kicking up the pH, so it's going to be a pH greater than 7.4, and acidosis is sliding the pH down. So I don't know if this helps when you look at the slide, but your alkalosis is going to be a higher pH, and if you're acidosis, you're a lower pH. So a little bit about acidosis. The pathophysiology at the cellular level includes respiratory and metabolic. This is an excess hydrogen balance by increasing hydrogen or decreasing bicarb. As your pH decreases, hemoglobin releases oxygen and picks up hydrogen and carbon dioxide. It will increase your pH, but it will decrease your O2 sats. Okay. As hydrogen and carbon dioxide increase, it stimulates the medulla, which will increase your respirations to blow off CO2. It can also cause cerebral blood flow vessels to dilate. So you're going to increase your blood flow, which will increase cerebral edema to your brain. And because of that increased pressure to your brain, you will have a decreased CNS activity. This can also stimulate kidneys to retain bicarb and sodium. It will excrete hydrogen ions, and your sodium bicarb will buffer that hydrogen. It will result in a higher pH, higher acid in the urine, a higher bicarb, and then your respirations will be decreased and they will be shallow. As hydrogen goes into the cell, potassium moves out to maintain electroneutrality. Hyperkalemia can occur, which can cause arrhythmias. You can have a decrease in oxygen, and your decrease in pH further depresses neuro and cardiac, so you may see your patient will have a decreased LOC with acidosis. So signs and symptoms of acidosis. Your respiratory and metabolic are similar, so you're going to be having to look at your lab values when you get them to determine if it is acidotic, if it's respiratory or metabolic. So depression of your CNS system, your neuromuscular system, and cardiac system can be related to hyperkalemia, and it can be related to an elevated CO2 level in your system. If you have CNS changes, like we were saying, because of that increased blood flow to the area, you will have confusion and lethargy. If there's neuromuscular changes, you may see a hyporeflexia and muscle weakness in these patients. And again, this is signs of acidosis. Some other signs and symptoms is your cardiovascular changes. Your patients may be bradycardic. They may be presenting in a heart block. They may have thready pulses and hypotension. So it's very important that if you suspect somebody is acidotic, that you want to assess your cardiac rate and rhythm to see if you can assess any of these cardiovascular changes. Respiratory changes include respiratory acidosis. If they have respiratory acidosis, they're going to have rapid, shallow respirations. And metabolic acidosis will be hyperventilation with increasing depth. An example of a metabolic acidotic patient will be someone that's diabetic that is having those Kussmaul's breathing. Integumentary changes will include cyanosis, decreased or cyanosis related to your respiratory system, again because you are having rapid shallow respirations, and you may actually see warm flushed skin in your metabolic acidotic patients. As your potassium goes up, they will become hyperkalemic, and you may see bilateral weakness and some temporary paralysis if this is not if it is not reversed. Okay, we're still talking about acidosis. I'm going to break it down a little bit more into your specifics with your respiratory acidosis, and the causes this is the alveolar hypoventilation and carbon dioxide retention, which is also known as hypercapnia. And here, if you look at these, you can kind of see with your ventilation and the exchange of your oxygen and carbon dioxide, and then what can cause it when you're not ventilating fully. Some etiology for respiratory acidosis. There's actually 4 main reasons. The first one is respiratory depression. So what causes respiratory depression in a patient? It could be a medication they're on, right? Some of the medications that we will see, and I think some of you have actually seen this in clinical, is if they're on narcotics, this can cause respiratory depression, hypnotics or sedatives, and then anesthetics. You guys are all going to the OR at one time or another, so the anesthesia you may actually see cause respiratory depression, and if this is not corrected, they could go into respiratory acidosis. Another reason could be increased intracranial pressure, which causes your cerebral edema. Remember, your vessels dilate in this case, and it will increase blood flow, which will increase that cerebral edema, that's going on in your brain. Another reason is inadequate chest expansion can cause respiratory acidosis. One thing could be a chest trauma. So if you have a rib fracture, that's really painful. So someone is going to be guarding themselves, and they are not going to be wanting to breathe as effectively as they normally should. They may have muscle weakness due to something like muscular sclerosis that can cause this. External constriction, if you have someone that's very obese and they have a lot of weight on them, it may be difficult for them to have adequate chest expansion. And also if they have ascites, okay, if somebody is in liver failure and they're full of fluids like that, all that fluid's causing pressure on that, which will also decrease their chest compression or expansion. And then if they're in respiratory arrest, okay, if they're in respiratory arrest, they're not breathing, so you're going to have inadequate chest expansion, obviously, at that point. Etiology continued. We also have got airway obstructions. Okay, so if you have an internal obstruction, this could be retained secretions or mucus. You have someone that's got a lot of that going on in them, that could actually cause respiratory acidosis. Or if they have an obstruction of food. Okay, we have patients that come in all the time that say they feel like they have something caught in their throat. And if it's large enough, obviously, we always want to worry about their airway. But if it's lodged to where the point they're still able to breathe, but they're not breathing fully again, they could have respiratory acidosis. So obstruction of food is another one with airway obstruction that can be have a cause of respiratory acidosis. Also cystic fibrosis, right? Their poor lungs are fibrotic. They are unable to exchange the gas the way they're supposed to, so they are also at a risk for this. Someone that has bronchoconstriction or laryngeal spasms, so someone has an asthma attack, can also have respiratory acidosis, or an external obstruction. So if somebody has a lot of neck edema due to some reason, that can cause this also. Also, that could cause respiratory acidosis is a reduced alveolar capillary diffusion. So what does that mean? If we have a reduced alveolar capillary diffusion, we're not exchanging our oxygen and carbon dioxide correctly. So some things that can cause this is if they have an acute pneumonia, if you have a patient that is having a COPD exasperation, somebody in pulmonary edema will have this also, and an acute drowning can also cause these types of things. So there are acute and chronic situations. If it's an acute phase, and that's more what we're focusing on with this lecture, the pH will drop below 7.35. So that's what you're going to be looking for as far as pH. Anything below 7.35 is acidotic. If it's chronic, often the pH will remain within normal limits due to the compensation. Your body has learned to tolerate whatever chronic condition is going on here, and it does tolerate it. So it will be below 7.4, but it's not going to be below your 7.35 because, again, it's compensating. I don't want you to get too confused with that because you will be going over that in your third semester class. Okay guys, so here we go. Respiratory acidosis. These are the labs, and you do need to memorize these. Okay, in the end we're going to go through all of them, but if they have respiratory acidosis, your pH is going to be less than 7.35, okay? And your PaCO2 is going to be greater than 45. Your bicarb will be normal. Your normal range is 21 to 28 milliequivalents per liter, and your PO2 will be decreased. Usually that means that it's under 80. If you have someone very elderly, over 90, it would be under 70. I don't want you to spend too much time confusing yourself. The normals just mostly are 80 to 100. Okay, so it's going to be below 80. Your electrolytes, usually the potassium will be elevated. So what does this mean with collaborative care? You know, we want to do treatments focusing on improving their ventilation. Again, airway, airway, airway. I know you guys probably get tired of hearing me say this, but that is your first thing. If you don't have an airway, you can't do anything else about this. And your gas exchange. Okay, so once you got your airway, how are they breathing? You want to make sure you have improving your gas exchange also. So you always want to assess your client's rate and rhythm and depth of respirations. Okay, this is very important to see, you know, as far as if they have possibly doing correct gas exchange. So if you see someone that has an abnormal rate, rhythm, or depth of respiration, and you're working like on a medical floor, you know, like on 2P or 4P or 1 North, and you suspect something like this, call rapid response. Okay, they are the experts. They can sit here and assess your patient a little bit further and get an ABG ordered, you know, and get other things ordered if needed. But remember, rapid response is your friend, and do not be scared to call them if you suspect there is some poor gas exchange issues going on. And again, the best way to do that is if there is a change in your client's rate, rhythm, and depth of respirations. If it's a non-pulmonary cause, you want to treat the underlying cause. Some medications, if a cause is ineffective breathing, you may want to put them on oxygen. You know, just be cautious with COPD. You give them too much oxygen, that's going to bring their drive, their respiratory drive down. But for most patients, oxygen is a good thing. Bronchodilators may be given to open constricted airway. Mucolytics to clear out those secretions that could be causing this. Anti-inflammatories may be just specific to the problem only. So you're not just giving a general anti-inflammatory. It has to be, you know, for a specific reason. If they have a specific problem to decrease that inflammation. Drugs to treat hyperkalemia if their potassium is very elevated. And then an antibiotic to treat infection, like if they have a pneumonia. You know, they will need antibiotics on board to help reduce this respiratory acidosis. Some other collaborative care that you can do is pulmonary hygiene. So encourage your patients to cough and deep breathe. Position them. If they're lying down, if they're slouched down, sit them up. You know, help them get their chest expansion going. They need fluids. If they've got a lot of excretions, you need to suction them and get those out so they can have an effective chest expansion. And they may actually need ventilator support. So some patient education that you would do is prevention. You know, some of these things can be prevented, so you do want to educate them about their disease processes and things to look out for so that they do not have to go through this if necessary. You also need for rest, because if they've gone through some sort of respiratory acidosis, you know, they've got something going on to where they will need to rest to help their body compensate for this. they also need to keep safety in hand. You know, they are a risk for falls. You know, like if you have an increased cerebral edema, you may have a decreased LOC, and you are at a higher risk for falls. You know, or you may have impaired memory because of this. So, you know, it's really important to keep your patients safe. Okay, so that in a nutshell was respiratory acidosis. We're moving on to metabolic acidosis. And what causes this is a gain in acids or a loss of a base, which is your bicarb, from the plasma. It may be related to fat breakdown. Okay, it may be related to fat breakdown, which will break down into fatty acids and then ketones. Some conditions that may cause metabolic acidosis is diabetes. Your respiratory rate will compensate by increasing your respiratory activity and blowing off your excess CO2. Okay. You also have got chronic alcoholism that can cause metabolic acidosis. And a big one that we do see a lot, especially with our homeless or our population that abuses alcohol, is severe malnutrition. So remember, severe malnutrition will put your patient at risk for metabolic acidosis. Also, a low intake of carbohydrates. You know, so a lot of those diets out there, people are not eating carbs. If they are doing this consistently for an extended time, those low intake of carbohydrates can cause metabolic acidosis. So keep that in mind too, because there is a lot of people that do those types of diets, so you may see those. Other things that cause metabolic acidosis is hyperthyroidism. A severe infection can cause this. And then pancreatitis is another big one that we do see. Pancreatitis is a major site of bicarb production. It can cause metabolic acidosis by underproduction of bicarb ions. Some signs and symptoms: if someone has an acute pancreatitis and they're in metabolic acidosis, they may be very lethargic. And again, they may have those Kussmaul's respirations, okay, where it's those deep respirations. They're trying to blow off that excess CO2. It may be caused by decreased ability of the kidneys to excrete acids, so they may be in renal failure or have renal insufficiency. It also may occur with excessive GI losses. So what's one of the main GI losses that we see that causes this? It's diarrhea. Okay, so if you have somebody that has a lot of diarrhea, you want to be on alert for this. You know, if they have an acute C. diff, that's a lot of diarrhea coming out. Just be on alert. They could have metabolic acidosis. They are at a higher risk for this for sure. Other things with excessive GI losses from an intestinal malabsorption and ileostomy drainage. So if it's a lot of drainage that's going on here, that could cause this. Or if they have a large fistula, that could also cause metabolic acidosis. Also, too much lactic acid can also cause shock. It'll put someone in shock. They could go into heart failure. If they have seizures, that is also a metabolic acidosis. Or strenuous exercise. Okay, so you got someone that decides that they want to lose some weight, they got that new resolution going on, and they work out way too much too fast. They can actually put themselves in metabolic acidosis. Some neuromuscular changes that you may see in these patients could be a reduced tendon reflexes and decreased muscle tone. Okay, so they're not going to have a lot of tone, and their reflexes will not be normal, as you would see. They could also be very drowsy due to these neuromuscular changes, and you'll see an increase in their respiratory rate because, again, they're trying to compensate for that metabolic acidosis. Okay, so labs. Again, ABGs, your arterial blood gases, is what you're going to be usually analyzing, and what your patient will have ordered if you suspect any of these. Again, this is arterial levels, okay? So your pH is going to be less than 7.35, just like your respiratory acidosis, right? Acidosis always is lower. You have that excess hydrogen ions that are kind of floating around, and you're acidotic. So your pH is less than 7.35. Your PaCO2, though, in this case, is normal. And then your bicarb is less than 21, so that is also low. So metabolic acidosis is going to have a lower pH and a lower bicarb. They're going to be going down the same. Okay, with electrolytes, your potassium may be elevated. If you have somebody in diabetic ketoacidosis, their blood sugars will probably be over 300. So treatment, if you have somebody in diabetic ketoacidosis, we're going to administer rapid-acting insulin and monitor potassium levels. The potassium levels will drop when acidosis is corrected. One thing that you want to keep in mind too with treatment in somebody that's metabolic acidosis is we usually will give them sodium bicarb. Sodium bicarb is one of those very traditional, very well-known treatments that we will give to kind of soak up that acidotic area and make it more neutral. So we give sodium bicarb. If they have renal failure or drug toxicity, we may do dialysis to reverse this, and they may need a ventilator for respiratory decompensation. So what do we teach these types of patients? We want to educate specific to the cause. So if they're diabetic, obviously we want to teach them about diabetes and proper diabetes care. If they're in renal failure, why did they go into renal failure? And educate them about that so they can try to avoid these types of situations. If they're malnourished, sorry, there's a plane that's flying overhead. It gets awfully loud around here. So anyways, if they're malnourished, treat your client to eat 3 well-balanced meals and a snack each day. That's ideal. Now, if they actually do that, that's another thing. So this is, again, where you want to use your resources. And if you can get dietary involved or social work, if it's somebody that can't afford meals, to try to figure this out. But again, malnourishment is a big risk factor that will cause metabolic acidosis. And a way that they can go and reverse that is to have proper nutrition. So 3 well-balanced meals and a snack will help reverse those situations and keep them from ever having to do this again. Okay, so this here is just a picture of metabolic acidosis. There's just some of the things. They may complain of headache, your altered LOC, maybe disoriented, high potassium. You'll see that muscle twitching possibly. You'll have that Kussmaul respiration that's going on. And then again, if you look down, you got your pH is below 7.35 and your bicarb is low. This is 22. I say 21. It's not going to be right on the edge there. You guys will know. Usually 21, that's what Iggy has in there, so I'm going to go with that. All right, alkalosis, moving on. Okay, we're halfway there, guys. The pathophysiology at the cellular level means that the respiratory and metabolic, the excess of base balance is due to decreased hydrogen or increased bicarb, so they're going to be alkalotic. So the pH will be increased. Okay, this is going to be higher than 7.45 when you're looking at these cases. It stimulates the cardiovascular system, so you're going to see an increase in your heart rate. You may see ECG changes. So I'm not going to have you identify these on strips, but you may see a prolonged PR interval or a depressed ST. Okay, so just so you know that those are some ECG changes that do occur. An increase in pH also will stimulate the medulla and the CNS, but this time, because it's alkalotic, it causes vasoconstriction. So you're going to have decreased blood flow and increased hypoxia systemically and to the brain. Okay, so again, this is more of a hypoxic event when they're alkalotic. Okay, cellular pathophysiology continued in alkalosis. As you see an increase in your pH level, you may see hydrogen ions move out of the cells and potassium moves into the cells. This is opposite of acidosis. There will be a decrease in your pH levels and a decrease in your potassium levels. Also, as the pH increases, it stimulates the kidneys to excrete bicarb and sodium and retain hydrogen ions. Also, as your pH increases, it inhibits calcium, which will cause an increase in neuromuscular excitability. Okay, signs and symptoms. Respiratory and metabolic alkalosis are similar. You may see a stimulation of the CNS, neuromuscular system, and cardiac system related to hypocalcemia and hypokalemia. CNS changes are also stimulated, so you may assess hyperreflexia or irritability. Your client may complain of paresthesia, where they may have numbness around their mouth and toes, and you may see someone having seizures. Neuromuscular changes due to the decrease in potassium and calcium, you will assess certain things. If they have a lower calcium level, they may be complaining of tetany and cramps. You may assess a positive Shavstek sign, and this is a twitching of the facial muscles in response to tapping over the area of the facial nerve. So the facial nerve is kind of located below the ear. So if you tapped your client below the ear, you may see facial twitching because of that, and that is a positive Shavstek sign. You may also assess a positive Trousseau sign, and this is a carpal pedal spasm that's caused by inflating the blood pressure cuff to a level above systolic pressure for 3 minutes. So by holding pressure to the arm for that long, they may start to develop carpal pedal spasms, and what that really is a cramping of the hand. So you will see the fingers start to curl in as well as the wrist. If they have a lower potassium level, they may be complaining of muscle weakness and may complain of difficulty breathing. Cardiovascular changes. The cardiovascular system is irritated, so you may assess tachycardia on your client, and they may have arrhythmias. And then respiratory changes. You may see a decreased respiratory effort due to the skeletal muscle is weak, and this is primarily with metabolic alkalosis. Okay, so specifically here, respiratory alkalosis causes, main one that you will see is hyperventilation. Okay, if they have hyperventilation, they're trying to blow off the excess hydrogen and CO2, which means they will have a decreased CO2 level, and they will have hypocapnia, okay, which will increase your pH, so they will be alkalotic. What causes hyperventilation? Fear can cause you to hyperventilate. If you're anxious, or you have a history of anxiety, if you're in a lot of pain, that can cause hyperventilation. Some medications that can cause this, nicotine. Aminophylline is another one. It's AMINOPHYLLINE. Some of those can also cause hyperventilation. Another thing, this is a good one to know also, is if they're on a mechanical ventilator, that can also cause hyperventilation and put them in respiratory alkalosis. So just as you're taking care of your more acute patients that are on a ventilator, just make sure that you work closely with respiratory, because if the mechanical ventilator is not under correct settings, this could also cause respiratory alkalosis. All right, so labs for respiratory alkalosis. Again, we're always looking at our ABGs, our arterial blood gases. Your pH for alkalosis is going to be higher, so it's going to be above 7.45. Your PaCO2 is lower, it's going to be below 35, and your bicarb is normal. Traditionally, your electrolytes, if they're respiratory alkalotic, your potassium will be less than 3.5, your calcium will be low, less than 8.6, and your chloride will also be low at 97. So respiratory alkalosis, again, your pH is high and your PaCO2 is low. So you're going to have an inverse relationship, and then that's what's causing the respiratory part of your alkalosis. So treatment for respiratory alkalosis, treat your underlying condition. Okay, so if they're anxious, you want to try to help them calm down, stay with your patient. When they're hyperventilating, again, they do a lot of times have these carpal pedal spasms, which are painful to them because, again, like their hands and their feet will start cramping up and curling in, and that they're like, don't know what's going on with them. It gets them even more anxious. So explain to them. Take some slow, deep breaths. try to get control of that so that they stop hyperventilating. Also, if they're hyperventilating, what will help is have them breathe into a bag. Okay, this will force a client to breathe exhaled carbon dioxide, which will raise their CO2 levels. Okay, and once they start feeling better, they will hopefully stop hyperventilating. If they're on a ventilator, remember mechanical ventilation is a big cause of respiratory alkalosis. You want to adjust the mechanical ventilation settings. You want to decrease your tidal volume or number of breaths per minute. Okay, and again, usually, at least at Tri-City, our respiratory therapists are the ones that usually adjust those types of things, so work in conjunction with them if you think your patient is having respiratory alkalosis, or if you have an ABG that shows this and they are intubated. Monitor your vital signs. If they're hypoxic, give them oxygen, right? And then you want to provide rest after their respiratory rate returns to normal. Give them time for their body to compensate. So some patient education, some anxiety reducing techniques. Again, slow, deep breaths. Tell them just to think of something calm. You give them some controlled breathing techniques, something just to help them so they don't hyperventilate. Okay, that in a nutshell is your respiratory alkalosis. This here is a picture of respiratory alkalosis, so you can see the inverse relation. You have a high pH and a low PCO2. Many times these patients, you'll see seizures, you'll see deep rapid breathing into hyperventilation, and when they're doing all of this, they could be confused, they have hypokalemia, and they also have lightheadedness and those tingling and cramping of the extremities. Okay, that is respiratory alkalosis. All right, guys, the last one we're going over is metabolic alkalosis. Okay, and some causes of metabolic alkalosis include a loss of acid or excess bicarbonate in the body. Metabolic alkalosis can also be caused by vomiting or gastric suctioning. There's a loss of stomach acid and hydrogen ions. Some medications may also cause metabolic alkalosis. Excessive ingestion of antacids. So if you have somebody that is taking a lot of Tums, this can actually cause metabolic alkalosis. High doses and prolonged doses of corticosteroids could cause this. And diuretics causing depletion of potassium, like your loop and thiazide diuretics. And this is due to the increase in the excretion of hydrogen ions, leading to excess acid loss through the renal system. This situation is an acid deficit of metabolic origin. Also, somebody that is on TPN is at a risk for metabolic alkalosis. So signs and symptoms that you may assess with somebody that has TPN that is in metabolic alkalosis could be a positive Schaff-Stick sign. They usually have a normal or low blood pressure, but they will have tachycardia and skeletal muscle weakness, and they may have anxiety and irritability. So that's kind of going over, again, some of the signs of metabolic alkalosis. Some labs. Okay, so we draw our ABGs. If somebody has metabolic alkalosis, this is what you're going to be looking for. Their pH, again, is alkalotic, so it's above 7.45. Their PaCO2 is normal, but their bicarb is also elevated, so it's over 26. Okay, so you're going to elevated pH and an elevated bicarb with a normal PaCO2. That is your cardinal way of checking to see if they have metabolic alkalosis. Potassium is going to be low, less than 3.5, calcium low, less than 8.6, and chloride low, less than 97. But those ABG, those results, your pH, your PaCO2, and bicarb are your main components to identify if somebody has metabolic alkalosis. So treatment, we need to prevent further losses of this bicarb. Okay, so thiazide diuretics and NG suctioning are DC'd. Okay, so that's something obviously you have to work with your physician with, because if they still need these, we need to come up with something that's going to help with them. But if they are having a full metabolic alkalosis, we need to reverse that. So again, thiazide diuretics or your loop diuretics and NG suctioning are DC'd, so we need to work with them on that. Need to give them antiemetics, okay, because again, vomiting again was a cause of metabolic alkalosis. Antiemetics will hopefully stop that. Okay, so anyways, make sure if they have a lot of vomiting, they get antiemetics. And then also work on restoring their fluid balance, because if they are vomiting, they are losing fluid, so we need to go and reverse that. They may get Diamox to increase excretion of bicarb by the kidneys. Okay, so you see that up there. It's Diamox. That's a type of medication that will increase excretion of bicarb by the kidneys. So what do we teach these patients? Mostly it's medication, the overuse of antacid. Again, if they're popping those Tums like candy, and they have metabolic alkalosis, that's probably what caused it. If they are taking a loop or thiazide diuretic, the adverse effects of diuretics, they may possibly put them back on these, but at a lower dose. So kind of teach them some signs and symptoms to look out for that also. So memory joggers, guys. Okay, that was it. Piece of cake, right? So we're going to be looking at our memory joggers. These may or may not help you out. I really hope you do listen to this before you come in and read the chapters, so then I can give you some numbers and we can figure out what they are together, so you get some good practice on this. So normal pH levels is your 7.35 to 7.45. Okay, the average of that is 7.4. That's right in the middle. I always remembered it because your pH levels are 7.35, 7.45, and your normal PaCO2 is 35 to 45. Okay, so those are, I relate them like that. So I always remembered it. My PaCO2 was 35 to 45. Your PaCO2 and pH move in opposite directions. Okay, so if you have a high PaCO2, you're going to have a low pH. And vice versa. If you're going to have a low PaCO2, you're going to have a high pH. Your bicarb and pH move together. So your high bicarb will have a high pH and vice versa. If you have a low bicarb, you're going to have a low pH. Okay? That is going to be your metabolic. When they move together, when they move opposite of each other, it's your respiratory. Okay, again, opposite is respiratory, so a high PaCO2 and low pH, or if you have a low PaCO2 and a high pH, that's something respiratory that's going on. And then if you have something that moves together with your pH and your bicarb, and those are moving in the same, that's metabolic. So how do you interpret an ABG, your arterial blood gases? There's 3 numbers that are related to your acid base. So your normals, again, you do have to memorize these. So get these imprinted in your brain. The pH is 7.35 to 45. Your PaCO2 is 35 to 45 milligrams of mercury. Okay, and then your bicarb is 21 to 28 milliequivalents per liter. So again, just make sure you memorize these 3, because you're going to have to know these to figure out what exactly is going on with your client's ABG. So there's 3 steps. Step 1, you'll be checking the pH. If the pH is abnormal, then you want to figure it out. Okay, so if it's below 7.35, it's acidosis, or if it's above 7.45, it's alkalosis. Sorry, here's the slide right here. So the pH, if it's abnormal, again, acidotic is below 7.35, alkalotic is above 7.45. Which system is causing a problem, respiratory or metabolic? So you want to look at your PaCO2. Is it high or low? Does it correlate to the pH? So it's respiratory if the pH is low and the PaCO2 is high, or if the pH is high and the PaCO2 is low. So if your PaCO2 is below 35 or above 45, something respiratory is going on. If it's normal, it's not going to be respiratory in nature. Step 3, you want to look at your bicarb level. Okay, is that high or low? If it is high or low, then it is metabolic. Okay, so if the pH is high, the bicarb should also be high, or if the pH is low, the bicarb should also be low. If they are in correlation like that, then this is a metabolic problem. Another thing that sometimes people use is Rome for your acid-base mnemonic. Respiratory is opposite. So you got your pH up, PCO2 down, or pH down, PCO2 up, or metabolic is equal. Your pH and bicarb both go up, or your pH and bicarb both go down. Okay, so that's Rome. Respiratory opposite, metabolic equal. Some other numbers found on the ABG result. Oh, I'm sorry. These are just 4 slides. So respiratory acidosis. Here's an example of one where your pH is 7.25. Your PaCO2 is 60, right? So you got a low pH, which is acidotic. And then it's opposite. Your CO2 is opposite. It is 60. So that's respiratory acidosis. And then the bicarb is 25. So that again is normal. Remember, your normal bicarb is 21 to 28. So if you look at this, respiratory pH 7.25, which is acidotic, PaCO2 is opposite, it's higher, 60. So that's respiratory acidosis. So Rome, respiratory pH and PaCO2 are opposite. Metabolic acidosis. Your pH is 7.2. Your PaCO2 is 40, which is normal, but your bicarb is low at 15. Okay, since your pH is below 7.35, it's acidotic. Your PaCO2 is normal, and your bicarb is low. So again, your pH and your bicarb are both going down, so that's metabolic acidosis. So we're going down with the pH, normal for PaCO2, and down for your bicarb. Rome, metabolic, pH and bicarb are equal. Respiratory alkalosis, your pH is 7.49. Okay, so that's elevated. Your PaCO2 is lower, so you're doing opposite again, and your bicarb is normal at 23. So you got high pH, which is alkalosis, low PaCO2, which makes you respiratory, and bicarb is equal. So here's your respiratory pH, and PaCO2 is opposite. And then our last one is metabolic alkalosis. You have a high pH, 7.5. Your PaCO2, 42, is normal. Your bicarb is also high. So we're going to do high pH, normal PaCO2, and elevated bicarb. Here's your Rome. Metabolic pH and bicarb are equal. They're both going up. Just last bit here, some other ABG values. So you don't necessarily need to memorize these things, but some of them I think you already know. Your PaO2 is the amount of oxygen dissolved in the plasma. Normal is 80 to 100 milligrams of mercury. Less than 80 milligrams is known as hypoxemia. And it's, again, it's important to kind of understand that, but it's not necessary for acid-base status. And then your SaO2 is the percentage of hemoglobin that is carrying oxygen, and your normal is around 97%. Your base excess reflects the degree of acid-base imbalance. Normal base excess is less than or greater than 2. Okay, so that's a normal for your degree of acid-base imbalance. Once you start going more than that, you've got to start wondering if there's some compensation going on. So that is it, you guys. I know this was a lot of stuff, and it's probably very overwhelming. So again, please listen to this, write down your notes, kind of figure out what your main causes for each of your problems are, your respiratory acidosis, your metabolic acidosis, respiratory alkalosis, and metabolic alkalosis. and memorize those norms. Okay, so then when we come in on Wednesday, we can go over all of these and we can practice them and then make you guys feel more confident on being able to analyze someone's ABG. All right, guys, have a great weekend, and I will see you on Wednesday.